And welcome to the February 12th, 2025 meeting of the Town of Littleton Board of Health. In attendance tonight, we have Matt Wason, Dan Kane, Kevin Davis, and our Health Director, Francis Daigle. We have a quorum, and so we will get started. Our first agenda item, 7 o'clock discussion, how to approach non-compliant food establishments. Francis?
Yep, thank you. So we briefly just touched on that last meeting at the end. While we're setting up things, it'd be good to have a standard operating procedure going forward and how the board would like to address chronic violators. So I think we're going to have one coming up, and I think it'd be good to have something in place for everybody at this point, really, to determine like how long you want to let it go, how many repeats until there is some form of action, and when do you want them to appear before the board. So just as for consumption, essentially when we're doing a food inspection, there's 3 categories of violations. So there are what's called priority foundation, and core. Core is typically like non-critical violations. It could be like dirty walls, dirty floors, equipment related stuff. So non-critical. Priority and priority foundation are both higher risk. So priority is directly leading to foodborne illness. Foundational would be more things that are directly related to that. So it's still high risk, but it's not as high risk. So when we're marking things down based on violations, not necessarily pass or fail, it's just a matter of how many violations and how critical they are is how we kind of determine how to go forward. So typically for priorities, it's going to be 24 hours because it's very serious. Priority foundation, depending on the severity and how much it's contributing, can be up to 10 days. It's up to the discretion of the inspector. And then core can be done at the next routine inspection, but typically I would like walk in 2 weeks to do a spot check and make sure that they're not still doing it. So the question comes down to, so when we're looking at non-critical, how many, if we have someone who just has non-criticals every single inspection, how many times do we want to let that go before we say, hey, you have to go to the board? Or, hey, you've been doing so many violations that I'm going to have to start fining you? Or do we fine per violation? So that'd be the first question.
Before we dive into the discussion, the time frames you just described for those, are those set somewhere regulatory wise?
Yep. So those are the FDA set standards.
Okay.
Does this
part of the reason I asked is because I know historically I've seen some paper reports that had like 30-day follow-ups for some sort of problem that needed resolution.
Yeah, the core category of violation is like really open-ended. It could be to the next one. So yeah, it could be 6 months even. I mean, leaving something past 30 days is really probably not okay. But so typically for how I do it, I check in 2 weeks after.
No, I much prefer an answer of 2 weeks than, CU is fine. So even for something non-critical, it's still a finding. It's still something that we would rather see done better. And so, yes, I would much prefer a turnaround that's within at least 30 days. So I'm happy with the 2 weeks. But that was my only clarifying question there. So Francis has asked the board a question. Who wants to dive in first?
So
go ahead, Kevin.
So I'm assuming because it's Massachusetts, there's a whole host of regulations and laws that establish the inspection and follow up there. Is that correct?
Kind of. Establishes the inspection. It establishes what areas that you're going to look at and what violations, and it constitutes the level of risk.
And then is it up to the individual towns to then hand out, this is the, reinspection times, this is, like you said, how many numbers kind of go, it's all up to the individual towns to do that?
It is, yep.
And so I've kind of looked a little bit also trying to look around, and there seems to be a pretty wide latitude on what towns do, what towns have done historically. Sorry.
Yep.
And it seems to the state and the courts seem to give us fairly wide latitude on what we want to how we want to enforce it.
Yep, absolutely. Nail on the head.
Okay. I'd like to think about it from a risk chart. So when you're dealing with program management stuff, it's kind of the things that I deal with every day. We kind of come up with a risk chart, and the risk chart generally has the top right quadrant being your areas in red, and then it kind of goes to a yellow, then it kind of goes to a green. And the X and Y axis you can define as a bunch of different things. So maybe it's number of criticals, number of mids, number of lows, or whatever, those three different levels. It kind of goes into this risk chart, and then you can kind of say, this is where it is, this is where it is, kind of go. We could establish that, and then depending upon where they land and like how they've gone through and removed the inspection, the defaults, or not defaults, the defects in their inspection, you then would say when you resolve it, it'll move you to here. When you resolve this, it'll move you to there. So when you get things in the green, you're good to go. But if you're still in the yellow or the red, you have to kind of still take action and have remediation. That's kind of my first thought on this.
Yep, that's kind of how I see it too. I was going to try to break it out in terms of further questions, talking about in the next step, critical and chronic. So I was just doing it a different way. Sorry if it was confusing.
No, it was fine.
No, it makes sense. Dan, you want to keep going?
Yeah, I mean, it's always a balance. One, just so we're all clear, the Mass and federal standard is health or food institutions should be inspected every 6 months unless they are classified low risk. And you have a standardized what constitutes a low risk, have that in place as an accepted regulation, and then you can shift an institution to a low risk. Some place that has a vending machine and snacks is much different than some place that's serving milk and baked goods or fresh meats, whatever. So, but our standard, I think, at this point, because we do not have a low risk established regulation, is every food establishment should be inspected every 6 months. So that, how long is that next inspection? Is it a year? Is it 2 years? It should be 6 months. As far as the chronic folks, I'm kind of in that same piece, is that I want to make sure we can be consistent. And the problem is we have so many variables that how do you make it consistent? Well, okay, so you get one priority. It's a critical that's going to be reassessed in 24 hours. And then, whether it's a month later, 2 months later, as a drop in, or 6 month inspection, you're having the same issue again. You know what? Okay, that's a pattern. You were addressed. It was remediated, but now we're back with the same thing again. That is a leadership organizational pattern. It seems unlikely it's a fluke. If your fridge temperatures are consistently warm, you went back, now it's fixed. 6 months later, it's warm again, or it's outside the safe zone. That's a pattern, and I think we need to address it as it's a pattern. If it happens twice in a row, what's a pattern for something like this? If I consistently walk into an establishment and floors are dirty, counters are dirty, that I don't think that necessarily hits priority unless you look working with cross-contamination kind of things, but it's a concerning pattern as well if it's repeated. But how do we, kind of that risk pattern, how do we balance? Okay, you get one priority and 3 cores, you get 10 cores, you get 5 priorities and 2 cores. At what point, I mean, I hate saying it kind of needs to be a bit case by case because you can't make it consistent, but there's too many variables, I think, to really come up with a guideline that can be consistently applied fairly. you get two criticals, and you have the same two criticals or two criticals in general, two inspections or three inspections out of the last, or two inspections out of the last three. That's a different piece, and it's time for a conversation, perhaps beyond the department level. I agree, it's important and it needs to be addressed. And I understand you're bringing it to us. I'm not sure the best way, other than how is the inspection? Are they? I know they're obviously checked, but are they scored? Are things you have critical? You have asterisks. I'm going to play my teacher role. That you have critical fails. You have asterisk items. You have to hit at least 80% of the items on your list. But if you miss a starred item, then it's an automatic fail. Those like that kind of mindset. Do we get? Is it your second automatic fail? It's before the board and an explanation. And is it a percentage overall? I'm not sure. I'm trying to come up with some way to making it consistent. And I admit I have not looked at a restaurant inspection form for probably about a year and a half now, to remember what's on the list. And I think they've changed since then. Can you kind of walk us through a little bit of kind of the items on there? What kind of thing?
Yeah.
What would a failed inspection look like for core only fails? So not any high priority, which would be that's asterisk start items. But what would it look like either a fail or a concerning inspection for core level? And then give me a couple, real, not necessarily real examples, but rather than food safety piece of, yeah, you're storing raw meat and, finished goods next to each other for a priority kind of fail. Just we have a sense of like what we kind of make sense of it.
Yeah, sure. So I guess to piece this out even more is, we can look at non-critical, and we can look at, chronic versus non-chronic, whatever. So when we look at critical, the next step beyond the board would be hiring a food safety consultant. And they would have to contract with them for 3 to 6 months, typically, depending on the severity, to be training. And then there's a question of when they get a food safety consultant, do we have them come every month with the consultant and the representative from the establishment to give us updates, or do we just have them send a report and we can review it as a group, and then make determinations how to go forward? So that'd be the next escalation above the board, if that's helpful. But in terms of non-critical, so you might have a wash rag that clearly seems it's not been in the sanitizer. Sanitizer hasn't been tested in a while. You might have a dirty wall from lunch hour. The floors might be dirty, especially during winter. You're going to get a lot of traction from the outdoors. So it's kind of facility messiness. So it's not going to cause a foodborne illness. But if you spot, let's say, prepped raw chicken sitting in a container out on the counter that's 54 degrees, that would be kind of your basis of what's critical. What is like, if you serve this, someone's going to die, someone's going to get sick. So it goes on a whole different, level. But there could be stuff like, let's say you don't have your sanitation strips, which is not foodborne illness, but it directly relates to not being able to test your sanitizer solution, which in turn leaves bacteria and germs on boards and everything else. So there's definitely a severity factor. So that's why I kind of like to do non-critical. So typically in the past, what I would do is usually if there's non-critical chronics after 4 inspections, I bring it to the board to say, here's the reports from the last inspections. Here's where the things are. Here's how these all tie into a foodborne illness that I think could be coming or graduating. And then the board reviews it and makes a decision. Okay, should we bring them to the next meeting to talk about it? Should we issue some kind of order letter or some kind of finding system saying that you've been a bad actor for multiple times, you've been warned by the inspector to do better food safety? Those are kind of low key. When it comes to critical and chronic, usually I think 3 times is kind of the max. So, a lot of stuff can be corrected on site. So I will tell them, you throw out the chicken right now. That's it. But they might be doing it every day as terms of their prep. You don't know. So then you ask their staff, okay, show me how you prep this. Tell me when you prep this. Give me a list of employees who prep this. and you kind of figure out what their process is, and you try to work with them to educate them how to cut down on time and how to make sure that's done in a certain way. So you say, let me see a chart. I want you to, notate when you do these steps, and I will randomly spot check you. And that's kind of how I've treated those situations. And then if it hits 3 for any reason, I think it's either becomes a fine or it goes to the board. And depending on how severe it is, that's when I say I might recommend a food safety consultant might be appropriate at this time.
Thank you for the further detail, Francis. I know both Kevin and Dan were also hit on the same kind of, well, it's quantity and it's quality, and how are we going to take both things into account? And I think that you've got a lot of the framework already in your head already, which is great. And we're not going to be able to come up with a better system than whatever you're going to come up with. But I think our input is valuable, so we can kind of give the guidance. For example, on the non-critical stuff, my gut instinct before you were saying anything else was, if you have the same problem 3 times in a row, then that like you're not doing a good enough job. Something's not clicking with you, and there should be some escalation at that point. I think if you have repeated findings that are different in an establishment, I think that's probably going to be the hardest one to deal with. Every 3 weeks you go back and find a new core problem, but the last one's taken care of, but now we have a new one. Does that just become an endless spiral for you without some sort of framework? So I don't know. I don't have a good feeling for kind of how to guide that kind of scenario. But I would say for kind of repeat offenders, I think you said 4. I like I said, in my head, it was just 3 strikes. That seemed reasonable to me. If you're talking about the same thing 3 times in a row, then maybe the 4th finding brings it to the board, or maybe it's enough to bring it to the board after the 3rd. I'd be interested in other people. As for critical components, 3 seems too much, especially if it's a repeating thing. And so I feel like if you've gone in and had a critical finding, and you go back for a inspection and you find the exact same critical finding again, is that enough in your mind? Is that enough to say, oh, we are now at the escalation phase? I'm not sure. And perhaps what it should be is, depending on the criticality level, perhaps for the cores, it's coming to the board. And I assume coming to the board is just making them try to have some accountability and communicate to this group of officials what's going on. But perhaps when it gets into the foundation and the highest critical one, whichever that one was, should those have the fines included even at that point? Because they are more severe and they are more dangerous to our community. Kevin, you stuck your hand up.
Yeah, the other thing I'm curious about too is surveillance and then reporting, right? Remember how we had the thought of, here's the QR code to go back to find out your last inspection was here. You got a grade of negative 10 million or whatever. I'm not saying that that's a thing, but whatever. We need to, what kind of things are we putting in place to kind of show, okay, over the last 5 inspections, you were awesome. You got 3 lows, no mids, and no highs. What are those? How are we showing, like, over time, how well the inspections are going and things like that? So that way we have some surveillance.
I mean, for the most part, there should be no violations, and that's kind of how you go. Is if you're a good actor, then I will see you in 6 months, and you're trusted to continue operations. But so, like, what I did during the inspections is, although it's required to be every 6 months, anybody who I wasn't really crazy about their inspection, they're now on a every 4-month schedule instead of every 6 months. So they basically have 3 inspections a year now instead of the 2. So I did that, I think, with like 10 places in town. So that's kind of how we treat tracking them and reporting them, is just being more frequent about when we go in and spot checking.
Is there,
I would say, Kevin, honestly, that it needs a short memory, because honestly, do I care how well you did 2 years ago? If you have critical findings today, I honestly don't. It's about today, because that's when we're using the establishment, and so the system is equipped to be able to keep track of the ones we need to revisit sooner, right, Francis? So that's what I care most about, so that if there's a finding and there needs to be follow up, the follow up is tracked. And so I think you're only caring about the history of the very recent, because there's been a problem. And so you're monitoring that more closely to say, there's been a problem, there's been a problem, there's been a problem.
do you think we need to escalate beyond 3 inspections a year? Do we think we need to, like, if you make it to the next inspection, 4 months later and there's more problems than there was the previous time, do you put them on an every other month inspection at that point? Where does the criticality?
Well, I think he's saying that the cadence increases for places that are potentially problematic. But if you have findings, you're getting repeat inspections almost immediately until you've
Yeah.
shown that that's resolved, right?
I mean, at your most critical, cockroach would probably be where you would be like, yeah, I'm going to be in every week. So, like Dan said, it can be a lot of case by case basis too.
Yeah, absolutely. Okay. I'm good.
Well, but so the key question is, when does this board want to see the restaurant operator?
I think if you have repeated mid tiers, I think they need to have come in, and I think if they have the highest level, if they have the highest level, I think we need to be more aware of it, definitely. But then if it like happens again, then you need to kind of like, you got to go see the board or something like that. And that's my opinion. It's like getting sent to the vice principal, then the principal's office.
And I mean, honestly, perhaps 3 strikes works for all of the levels, knowing that if it's highly critical, the 3 strikes are just happening within a week, as opposed to something that's less critical, the 3 strikes are happening over months. So maybe that's sufficient to say, if you rack up the 3 strikes in the time frame of the re-inspections, then you're coming to the board before your 4th inspection, basically.
I also think if you have the repeated, like if you have missing test strips or something like that, and you have missing test strips 3 in a row or whatever it is, if it's the same violation 3 times in a row, like the exact same violation, I think somebody should kind of come in and have a talking with. I don't know what other bit everybody else says, but that seems to like, oh, you're not doing the right. Okay. The question is, what's the stick after that?
So one way we could do it is maybe I just bring it to the chair and the chair goes, we should send this to a meeting. They can make that determination.
Seems fair. What do you think, Dan?
I think the 3 strike in general is probably okay. I mean, we're looking at that point at really a year and a half or a year inspection, 6 months inspection, 6 months. So a year between first concerning finding and it coming before us, which seems like a long time of an ongoing pattern, but certainly for our lower things of non-food safety, cleanliness kind of stuff, is probably okay. That mid-level, truthfully, your dishwasher temps aren't high enough, or you don't have sanitizing strips, which means you tested through the first bottle, or you threw them away, and you never replaced your bottle because no one's checking until 6 months from now, or at that point, 5 months from now. It's not a concern in your head that I'm not sure if 3 strikes is easy. 3 strikes is easy. I think that's probably pretty reasonable. I agree with that. If it's, I've got a food board, I've got raw chicken next to ready to serve food, gets the education on it. You go back a week later and there's still, the behavior is the same. You go back a month after that, the behavior is still the same. It's back to us, and whether that's Francis ordering a consultant or us ordering a consultant. I think that's a pretty big stick, only because there's cost involved that is probably going to be significantly higher than fines we would levy. I think for us, the next big stick, because we can certainly fine, is going to be you're closed down until but that's the challenge at that point is, okay, so we've closed you down because you're storing raw chicken next to ready to serve food. Well, we've closed you down. You're not doing that anymore. When you open back up, are you going to in fact stop that behavior, which previous observations and remediation hasn't changed? Hopefully having to close for 2 or 3 or 5 or whatever days is a stick. I'm not sure how it's an intellectually effective stick. I'm not sure how effective it would be in practice. I'm just not sure. If I have to close down, yep, you teach me a lesson, but telling me beforehand that it's going to shut me down if I don't take care of my chicken appropriately, and I'm still not doing it, I'm just not quite sure if education is going to be effective in that case.
I mean, the one
I'm just not sure.
I mean, the one that comes to mind right now for me is norovirus as the example, right? I know raw food, raw chicken, things like that, but I'm also thinking like norovirus and things like that, because that's easily spread. Somebody comes in sick, blah, blah, blah. So,
I mean, in that case, we would shut down automatically anyway, because everybody would need to test. So that'd be the safeguard. Essentially, we would shut them down and then bring them to the board to discuss what happened and the results of the testing. So, I mean, certainly in terms of shutdown, there's a process too, separate in its own.
and I assume you have access to Maven as well, right?
Correct. Yep.
I think the only thing I want to clarify for Dan's comments was hopefully 3 strikes would never take a year, because if you've gotten a strike, it means you're getting a more frequent follow-up within 30 days, even for core, right? Ideally 2 weeks. So I see that as you're getting 3 strikes, even for something non-critical, that's happening within a couple of months, and we know about it. So, France, I feel like there's kind of reasonable consensus that 3 for a repeating thing. I think the other question is, what if it's not repeating? I feel like if you have critical findings, I would say 3 of any critical finding in a row is probably a reason to bring it to us. But when you slide down to the less critical things, I think that's the one area where you start to go, well, if every month you go in and it's something different, is 3 strikes enough to bring it to the board because there's not enough attention to detail going on? Or is that one where you want to perhaps, like you said, just converse with the chair and say, let's let this one go a little bit further and keep an eye on it and agree on a more stringent follow-up process? I would be okay with that.
Okay.
And then, do we have a fee structure set up as a regulation somewhere that we can actually use?
I don't think we do, actually.
Okay.
I will double check for the next meeting.
Okay. So some of this is going to be making a process for you to follow, but it sounds like we might also need to pass a regulation that says we can fine.
Yeah, I'll look into it further. I'll have an answer for the next meeting.
I know we have a town-wide violation fine schedule that, I mean, obviously any of our regulations fall under basically town bylaw. So we should be able to fine under a violation of a inspection violation, I believe should be enough to trigger a regulation violation if we chose to go that route early on, as opposed to warnings. but we could certainly look at that. Is it effective and clarify it if we want to? But we should all health board of health regulations have the same enforceability as town bylaw, so it should fall on the town bylaw fine schedule.
We wrote something, and I recall we basically copied the town one, but we included it in our own document. Maybe that wasn't necessary for following the town. In this case, I would just make sure that it's not something like first offense is this, second offense is this, and it doesn't align correctly with what we're talking about. That might be the only reason that we would have to have a different one in this case. All right. Anything else on that topic, Francis?
No, thank you.
All right. Our next agenda item. I don't think we have any audience members today here. Nobody in attendance. So our next agenda item, 710, discussion on the opioid settlement funds. Take it away.
So I just want to give the board a quick update. So as we're looking at the funds, I'm also connected within the region as well. And that's a conversation we'll have to have at some point, is how much do we want to spend regionally and how much do we want to spend solo? So with the regional group right now, we've been moving along, and I did send the group a description of what a substance abuse prevention coordinator would be, and asked if there be any interest in that. There is some interest. The more established towns that work together as a group do have this type of position in place. It's definitely a viable option for opioid funds. And we haven't really gotten far in the conversation, but we've just thrown it at this point for them to bring back to their towns as well and discuss, and then we'll meet up again. So I just wanted to update the board early on where we are with the regional discussions.
Any questions from our group? Kevin?
No, I like that.
Working with our partners here in town, I know we've kind of gone back and forth a little bit on who kind of owns the process, who's driving the process. Do we have a sense of, is this under town administrator with advice and consent? Is this being driven by Elder and Human Services, by us, by law enforcement, by fire, or by like kind of what is that? It comes into the general fund, but it's dedicated what it can be spent on. I'm just curious who's driving it, or who ultimately owns the process.
Not by choice, but it was thrown at me. So I am guiding the process.
It's a lot of work, but not necessarily a bad thing.
It is. We're looking at a group called Advocate. The town also be with law enforcement. You know, there's a group called PARI, and I'm sure Dan knows. Yeah, that instead of going for the arrest route, it's more seeking treatment and connecting to resources. So I've asked to meet with Advocate next week to kind of discuss how that works, and if they worked in the town in the past, how that's worked as well. See if there's anything in there. I also requested in Sudbury, the health director there hired a substance abuse coordinator. So I asked if that person would be able to meet with me or the regional group and kind of discuss what they've seen as the role being, what the towns have gravitated towards in terms of focus, and having someone that's actually experienced in the role and knows the subject matter, where they say the focus should be right from the start and what they see as a pattern. Because obviously they probably talk to other ones as well throughout the state, because there's probably a good maybe handful, maybe 10 of them at this point. Like I said, more established towns have kind of gone that route because it makes a lot of sense having a subject matter expert be able to look at the problem, develop, implement, and build, rather than us trying to figure it out. So I should have some better ideas of where to go maybe and talk to the group further after I talk to them as well.
All right. I don't have any further questions either. So thank you for your continued work on those. And that takes us to our 7:20 p.m. discussion on the short-term rentals.
Yeah.
This document, there's a document included in our packet for review, talking about the short-term rentals. So, take it.
Sure. So I just want to put it on everybody's radar. Short-term rentals, sometimes the Board of Health becomes involved, sometimes they don't. Looking at the survey results so far, it seems to be a desire to have short-term rentals. Obviously, that could impact us as well in terms of septic systems, as well as having short-term rentals. So communities that typically do this, the boards of health should really go out and inspect the properties and also set a baseline for nuisance, noise control, that type of stuff. So even though it's still as a survey right now, I think it's good to kind of bring it up early on saying, do we want to be a part of that process? Do we want to start getting involved in maybe inspections or licensing to some degree these short-term rentals that may exist? And also it's interesting to look at the ADU where now it's changing as well as part of that, where it doesn't have to be owner occupied. And that kind of creates its own element in itself as well. So it might be something we might want to look at further as the survey goes on and planning is starting to develop, and whatever they may have, we might want to do a joint meeting with them or something like that.
Do you have a sense of what other communities do for this for the inspection process? I mean,
I've done it. So in my last job, we had in one of the towns, we had 3 kind of Airbnb type of situations. And so basically it's essentially what's called a certificate of fitness. So you take the human habitation standards from the code for the state, and it's kind of a miniature version of that, making sure all those elements exist in the house. So it's kind of like a dumbed down housing inspection, basically. So you just make sure the essentials are there. I'd create like a certificate of some form and make sure that they annually renew and we inspect. We'd also put in some kind of language about nuisance and noise and security and, stuff like that.
thank you.
Kevin?
You're on mute, Kev.
Sorry. I just want to make sure that we're involved in the process and make sure that the health stuff is actually like being brought forth with the town. That's probably my biggest concern, is that there'll be something that'll be done and it'll go against what we kind of like want to have happen. So making sure that we're involved is appropriate. Yeah, I like your idea about having a inspection form similar to what was there for a regular dwelling, but fit appropriately for the job that it needs to be done. Yeah. So like our dwelling unit zoning code right now in Littleton, it's like 1,200 square feet, but the one that the state passed was 900. So how do we kind of like rectify the two? Or do we make 2 classes? Do we have one where it's up to 900 square feet? It's these things that are, by right, and then things between 900 and no more than 1,200 have to follow all of the things that are already in the town. So that's kind of where I'm at.
Yeah, I thought it'd be good to bring up now too, because next meeting we'll probably talk about additions and basements and all that too as well. So looking at that in that context as well might be helpful. Thinking ahead.
Yep.
So, yes, I know that at least one time in history, the right to have an ADU was also interpreted as a right to go beyond the design septic size, which is not just an automatic stamp. Just because you might have the ability to create an ADU does not mean that you get to just supersede the rules required of your septic system. So I think we just as we kind of go down this path, we want to make sure the public understand that there are still rules that have to be followed no matter what's going on, whether you can have one or not. I agree with Kevin. I appreciate having some sort of just inspection system for a short-term rental. I would ask, what requirements are there for a long-term rental?
It's a good question. There really isn't on our side. It's still the same basic factors of human habitation. So, in terms of length of stay, we don't really have anything to do with that. But
Right.
with short term, it's more of a nuisance and it's more of an overcrowding issue as well. So, just kind of a different beast.
Oh no, it is. But it becomes a spectrum of, what do you do about a hotel versus long-term rental versus a short-term rental versus what's a medium-term rental, and so I think we might find ourselves someday into needing even more framework. But I appreciate that you're kind of getting in front of this now, and I'm curious to see how the survey continues to turn out. But yes, I'm of the opinion that something like this, because it becomes basically another quasi-commercial enterprise of housing, that there needs to be some good understanding by the board in the town of what's going on, what are the quantities that are out there. And I think it's not unreasonable to have some inspections and some licenses to have those things, right? If you want to operate one of these things, then apply through the health department and get your license and get your inspection, and you'll be good to go for a year. Is that the direction you're thinking?
Yeah, essentially.
Okay.
I'm assuming we already have some sort of inspections for the hotel that we have in town, right?
Yeah, once a year. A little different, but yeah.
Okay.
That it, Kevin?
Yeah, it's a.
Okay.
Sorry.
You were still churning. I just want to make sure.
No, all good.
I didn't catch that, Kevin. You mentioned that the Littleton ADU actually has a different definition for the size.
Yeah, so you can have, if you go look at you go into if you click on the Littleton ADU bylaw, it's 1,200 square feet. So I'm sitting there going, okay, if by right you have 900 square feet, great, peace out. Here are the requirements for those 900 square feet, right? To meet all of the language in the law that fits the 900. But then it should be an easy step up to the no more than 1,200 square feet, right? And here's what that says, because it's more. Does that make sense?
That's one way to look at it. Another way to look at it is we change our 1,200 to 900, and that's the category.
I hear you. It's a consideration.
Is there? I doubt it. Francis would potentially know. I don't know about anything else. Dan always knows the stuff. Is there? Did the state size change? Did it used to be 1,200? Do we know where our 1,200 came from? Any sort of historical?
Kevin seems to know.
I honestly think it was one of these grab it out of the airs. It would be interesting if somebody had some notes or minutes about how they discussed how that came about, but it wasn't us.
Well, we'll insert ourselves now. So
Yeah.
Because I think the state's always been 900.
Okay. No, I think that's a question that we should ask. Then is, I understand. Yes, we could have our own little. Well, up to 900 means this rule set, and from 900 to 1,200, you're kind of in this rule set. But is that what we want to manage?
And it appears that it's in the accessory dwelling unit. So I wonder if there is, let's see, Massachusetts accessory unit square footage. It's 900 feet in the state. That's interesting. Wonder where that came from. Okay, I'm done.
Well, and accessory dependent gets a definition of 1200, but accessory gets a definition of the smaller of 1200 or dimensional limitations set forth in a different article or rule.
Yay us.
Oh, then it's a percentage base, both floor area and land area.
Oh, attached accessory apartments.
Yeah. Okay.
All right, so I'll talk to planning, make sure that we're part of the process as it starts to go forward.
Sounds good. Next on the agenda then is 7:30, our infectious disease decision support tool. I will share that. Come on. There you go. So COVID-19 current variants, they're flip-flopping between the XCC and the KP.311. They're both Omicron variants. Both are expecting optimistic, reasonable cover for vaccination. The XCC one is the one that has been particularly transmissible. So it's spreading pretty well. I think it's a little surprised it has actually not spread further in our area, but it's at 38% for the New England area. Vaccinations sit at a whopping 30% as of the start of February. And you can see our weekly case counts are now going up for 4 straight reporting weeks, which is a concern. And I'll remind everybody that these case counts are only from identified cases in healthcare establishments and tests done that way, right? Your home tests don't count, and people who have COVID who just stay home for a couple of days or keep going to work for a couple of days don't necessarily show up on here. So the real number is bigger. So if you look at this and you say it's less than 10, that's no big deal. That's a minuscule percentage of our community. That's understandable, but at the same time, there are plenty out there that are not captured in this chart. That's the positive in that if the disease is not making people as ill, that means they're not going to be going to the hospital, potentially not going to their doctor as much. But I don't like the fact that it's going up and our vaccination rates are still low. The good news is the wastewater numbers have actually dropped over the last month. So perhaps this is a wastewater peak followed by a case peak. And maybe we're on the downswing of this particular wave, but that remains to be seen what it's going to be. I know I kind of mentioned last time and probably the time before that and probably the 18 times before that our vaccination rates in Littleton are just not good. They are not what we need them to be a safe and healthy community. We're getting to the point of this season where it might be too little too late if we were to bump it up. But I would say that we set ourselves a challenge for the next season because we have plenty of time between now and then. And I would like to see our health department, Francis, thank you, set a target and drive to try to meet that target. It only does so much for us to sit every 2 weeks and look at a number on a screen if it's not going to actually affect some change. So looking forward to next season, I think we need to come up with some solutions, knowing that this is how our track record has been, and try to figure out how we can get a better start on it and get better penetration for these programs. I'll scroll down. Influenza's better. We're at 49%, but still not where we want the community to be. For influenza, the flu, the last time I reported, which was probably 2 meetings ago, so a month ago, the status in Massachusetts was still low, and it has jumped up to very high now for influenza. So highest risk that they have, lots of cases going on. The CDC numbers show just a tremendous spike in influenza rates. The good news a little further down is that RSV is going in the other direction. So RSV is getting better, but the influenza cases are just shooting up. So I think their numbers we are up to. This is not for the Littleton, is for the whole state of Massachusetts, but we have 20% of emergency department visits are now due to some acute respiratory disease. So about half of those being influenza. So those are both numbers that I think we don't want to see. You don't want 1 of every 5 patients coming into your ER having some sort of respiratory illness, and half of which are influenza, which we know we have some vaccinations for, that if you get your vaccination, you're more likely to be kept out of the emergency room. So we're in the thick of respiratory illness season, and that's what's going on. Questions about these?
Just at-home tests like that can also detect the flu A and flu B type, as well as COVID-19. So for those people that are wondering, you can get a single test that'll look at all 3 at home. So that way, if you're feeling cruddy, you can see if it's one of the 3 and then call your doctor appropriately.
And then the other piece, I did not add it to the dashboard. We talked about it. Not sure if there's anything to add right now, but that's about the bird flu, avian influenza. So thank you, Francis. We have now information on our health department town webpage, and the CDC is obviously continuing to monitor it. 68 human cases in the United States, but still nothing near New England. I think Michigan, the Midwest, there's some few cases in the Midwest. So I think we're pretty low risk for any human cases right now. But as to your birds and fowl, please, please, please keep an eye on your animals. And if they show any signs of illness, that's when you need to be doing something about it to reduce the spread.
Yep. So if you go on our website, Fish and Wildlife have asked that anybody that sees problematic birds, that they be reported through their website. The form is on our webpage for that, as well as the contact if any animals personally domesticated are acting odd or feel sick. So.
Great. Can I show that really quick then? One sec. So here's our page on bird flu. So where should they go to report that?
I think it's near the bottom. Last one, yep.
That one. Oh, that's not a link.
Yep.
Can you have them fix
That'll be
that?
corrected.
And I wonder if that's important enough. If this whole section actually just could put right up here,
Okay.
because the rest of this is informational basically. But that one, if we're asking people to take an action, let's make it a little more prominent so that they know right up front in case somebody doesn't look that far down.
Okay, good idea.
Anything else on infectious diseases? Then we have 740 administrative matters, starting with meeting minutes approval. There are meeting minutes from the last meeting of January 22nd, which I was not present at. Therefore, we do not have enough members to vote to approve those minutes. Right? Okay. So we will have to push those to our next meeting. And that brings us to our last agenda item, which is correspondence and member updates.
I'm sorry to all those who missed out on Super Saturday. It was really fun. Thank you to Dan for being there.
Yes, thank you, Dan.
I did not do much. If anything, I made things worse because I was there in moral support and was placed in a position of more than that and without enough backstory. So I didn't help our case much, unfortunately. But was there any updates that you are able to or interested in sharing, or you can talk to the chair at regularly scheduled?
Yeah, it's still in flux. Kind of what we talked about. Yeah. So I'll let you know once I get an update either way.
Thank you, sir.
Right. Anything else, Francis?
We have an intern starting next week. Her name is Emmy. She's coming from Merrimack College. She'll be with us so the end of April, pretty much. She'll be working on opioid-related stuff, promotional and presentation-wise, is kind of where I think we landed. If there's time, she might do some more kind of educational materials. Also, we submitted our application to DPH for their grant intern program. So that'd be $4,000 a semester to pay an intern, place them with a project that we create. So that person we put as the for the community health assessment. So they'll help with that. That'll be a good help. We also, the CDC website is frozen and kind of has a check back later for the fellowship grant. Not totally unexpected. So, so I just keep checking every day and maybe it'll open one day.
All right. My only other question, Francis, was just to make sure that Jim Dugan gets the fee schedule.
Yep.
Okay. Okay. Any other updates, Kevin?
No updates from me. Thank you.
All right. Dan?
I don't think I have anything this one.
All right. I don't think I have any other updates. Like I kind of mentioned before the meeting, I am going to send a communication out saying that if you are going to be unable to attend a meeting, please communicate it to the chair at the time. I understand we all have stuff going on. Wednesdays have become particularly troublesome for me all of a sudden. Apologies for that. But thank you, Kevin, for picking up the role when I need it. But again, it's just make sure you communicate it, send it to the chair as soon as you know, and that way we can make sure we're canceling meetings if we don't have a quorum or trying to figure out if there's something else that we need to do to try to cover for it. I think it's hard if we expect people to be here and then they no show, because it can also really impact our ability to have fruitful discussion if we don't get to hear from all of our members. So I know this meeting tonight didn't have the heaviest of agendas and no public hearings, but it's valuable discussion time. And that's part of why I wanted to make sure we kept meeting twice a month, is because when we don't have proper business pulling us one direction, that's the time to talk about policy and regulations and continuing to move this board forward and our actual health department that we now have. So this could be a really exciting year for us. And I would like that to be exciting from a regulatory standpoint, not an exciting from an event standpoint, just so we're clear.
Oh, good. Okay.
So I'll get that sent out, but that's all I had. Therefore,
I'll make a motion to adjourn.
Second.
we have a motion and a second. Roll call vote. Kevin Davis,
Yes.
Dan Kane,
Dan Kane votes yes.
and Matt Wason votes yes. Thank you all for coming, and thank you for a good meeting.
Thanks, everybody.
Thanks, everybody. Thanks,
Thank you,
Francis. Thanks,
Francis.
Meg.